after this brilliant presentation, we know that endovascular technique are on the front of the scene right now. In fact, Dr. Parodi was a pioneer in 1990. He introduced the first concept of treating aneurysm with endograft. The endovascular treatment need a good patient selection using only approved grafts in, if possible, center of excellence. I know that in India you are not dealing much with this technique. It's why I want to be progressive and let you know how we're feeling. Surgical repair is still a good technique. It's a reference, but you need operative time, transfusion, clamping, and long time in the hospital. Anyway, the trend is endovascular, and there will be more and more patients treated, as Dr. Dietrich told in the press conference. And there are the new vascular surgeons. They are able to get the best material to treat the patient, from surgery to radiology to endovascular technique. The young generation must benefit from the history of endovascular technique. It's time to act for the youngest. You know that we need the structural integrity of the endograft with a total extrusion of the sac for long-term patency of this graft. Mensuration with sizing is very important. You can do it by yourself. You can do it by the technician of the company who are most of the time very well trained to do it. Take time to do it. You need 1 hour to do it, maybe 2, and try to select the best material for your case. Sometimes it's tricky. Sometimes it's not easy to pass through with a guide. So you have to anticipate the difficulty of your case before the intervention. You need a good suite, a good operating room, a good theater. You must need a sophisticated arm, if possible, a fixed system with a sophisticated image, sterile environment. It's still important. And you have also surgical security if necessary. Contrast injector is a must, a need. And you can do it percutaneously, but sometimes it's more expensive in terms of getting the product. Just little, small incision for the access to the iliac. The endograft development, basically 22 French, but it's getting down. The diameter of the access graft is getting down and down. So become more easy with time. Important, the angiographic geometry of the renal, because this is your best, the basis of your technique. You need to know where are the renal. For some time, a suprarenal fixation make your attachment, superior attachment, better for better application, saving the perfusion of renal. Here you can see the frame. Main body graft, modular branch. It's sometimes not easy to go with a modular branch on the other side, but with the experience is getting better. Be careful, the longitudinal force are very strong in the aorta. You can have migration and iliac rupture. Take your time before deploying your graft, and remember that you need a good sizing. Also, you have radial force, longitudinal force onto the graft. The grafts are getting better and better, stronger, thinner. So you can trust the approved graft right now. Because in the past, we had some problem, and we had some lack of solidity in the fabric. But now it's finished. This time it's finished. It's better. We have many grafts, many designs, and they are safe to get a good result like that after. Be careful to the length variability when you deploy with the curve and the anatomy of the... it's not theoretical. In the practice, you have some movement of your graft. So this comes with experience. The randomized study, I don't want to repeat that, but they are favorable to the technique. Less mortality and better outcome, as you know. So the surveillance is important. Control, avoiding handle leak. Surveillance with the plex, CT scan, with the time, with regression, and avoiding migration like that. This was a too short neck with the bad superior application. And you see, you have to go to surgery. Thrombosis could be an issue. Be careful always to the anticoagulation and the anatomy. MRI is not a good way to surveil. You can have metallic artifact. And you will need a surgical conversion only if you have a persisting type 1 embolic, increased aneurysmal size, or abdominal pain. So you have to work in collaboration with a surgeon. You have to have a group of people collaborating together on the same patient. And the future could be fenestrate endograft. In conclusion, it's a revolutionary technique. You need a good patient selection and an experienced team in a center of vascular surgery if possible, with a good surveillance using new generation of endograft. Thank you for your attention. For thoracic, I answer your question. The insertion is more difficult because you have a larger caliber of graft, and you have to anchor in a high streaming pressure. And there is some very good indication, like this localized aneurysm, and there is still a challenge with the geometry of the aorta and the access. You have now a large range of devices, and they are secure. They need to be conformable, flexible for a good apposition. They have to be adaptable, flexible, and to get this sort of result. The apposition is very important, so you have to take time for good sizing and use the radial force of your graft for a better result. But there is a problem of access because the material is big to introduce. 22 to 27 French, getting down, I admit, but it's not always the case. You have to deal with the iliac tortuosity. You have to straighten this axis intraoperatively by stiff wire. Be careful to the vessel access injury. That's the most common complication. You can use regular access, but you have to take in consideration this sort of vascular access complication. So sometimes knowing that it's access situation are risk, especially in women with a risk of rupture, you need to work with a surgeon in a good room and be careful to the stenotic iliac. Sometimes you will have to deal with severe tortuosity and to put a graft inside your access to be more secure, a temporary conduit for stenting. So I hope I could answer your question, and I hope I've been giving an overall view of the problem. Thank you. Yeah.